This is a presentation on the measurement of severity from claims data obtained. Comparative effectiveness indirectly helps in the measurement of severity with different cases. However, focusing specifically on comparative effectiveness, its purpose is to reduce cost and improve quality by providing information about what works best. The growing availability of health electronic records enables access to large data that can be used to study comparative effectiveness of medications. Very large databases now exist through the Veterans Administration's data warehouse and the Center of Medicare and Medicaid's chronic disease databases, for example. These data can be analyzed to understand how effective various treatments work. In case of poor outcomes, generally there is obscurity when accountability is concerned, when a severe incidence occurs within the healthcare organization, partly due to the multifaceted and dynamic workforce that exists, with a range from age, ethnicity, gender, and different disciplines all being a factor. Accurate measurements of severity of illness is important in understanding quality of care. In non-randomized studies, changes in outcomes of patient care are first attributed to the severity of illness to the patients before they are attributed to any particular intervention. It is a process of sequential attribution to the more plausible explanations. If outcomes have deteriorated, then the first suspicion is that the patients are sicker than average. When patient severity is ruled out as a possible explanation, then one might be concerned with patient's preferences regarding treatment. If neither the patient's severity nor the patient's preferences explain the outcomes, then one would have more confidence that perhaps poor provider's decision might be the cause. In order to find severity and its causes, this slide, for example, shows the clinical data that was obtained in this instance. As seen, there are 10 cases with 5 different diagnoses in which the length of stay varies for each of the respective cases. The final step is estimating the severity cost for each single diagnosis code and needs to be standardized with the scores ranging from 0 to 1. The regression coefficients of various diagnoses indicate the relative severity for each diagnosis in increasing length of stay. To use these data in order to establish the severity of a patient presenting multiple diagnoses, we have to standardize the coefficients so that they range from 0 to 1, with 1 indicating the most severity diagnosis within the entire database. In this case, CHF seems to have the highest severity score and therefore is assigned a score of 1. The least severity is the diagnosis of hypertension, which is assigned a score of 0. The remaining diagnoses are standardized to range between these two. The results are shown in the table above. Once the severity of each diagnosis has been established, the overall severity of the case can be established through various methods of aggregating multiple scores. The typical approach is to use an additive model, meaning adding the scores of each diagnosis. We do not think this is reasonable because it leads to counterintuitive scores where the more diagnosis the higher the severity score. Another approach is to set overall severity of the case to the average of the severity of each diagnosis within the case. This too is not reasonable, as the cases that have a diagnosis with low severity score will have lower overall scores. Hence, an overall severity formula as shown above is used. And using the Excel software, the above equation on overall severity was manipulated with the designated figures. After computation, the overall severity are found in the highlighted column seen above. For example, case 1 has an overall severity of 1, for example, while case 9 has an overall severity of 0.8. This graph represents a relationship between the length of stay versus severity, with the length of stay being on the y-axis and severity being on the x-axis. As seen from the regression line, it is a positive relationship between the length of stay and severity, with the length of stay increasing at the highest severity point, which is 1. Therefore, in conclusions, these data suggest that simple transformation of claims data within an EHR could produce more accurate measures of severity of patient illness, which in turn can improve the accuracy of comparative effectiveness data. Severe measurements, again, provide objective reactive decisions. Studying these situations and involving discussions among clinicians and administrators help to improve the quality and reduce costs for further costs.